I know you've discussed diabetes already in MedSearch 1, correct? I'll focus only on the acute complications of diabetes. And let me ask, you discussed hypoglycemia, correct? So you know mild, moderate, and severe manifestations of hypoglycemia. You know the causes of hypoglycemia, and you know the management. Yes? Why not? You discussed this already.
The mild, the
Okay, fine. All right. So here's hypoglycemia. So hypoglycemia is anything below 70. So that means our normal blood glucose is 70 to 110, correct? All right. So anything less than 70 is hypoglycemia. Now, what are the causes? One, too much insulin or oral hypoglycemic agents, too little food, or excessive physical activity, or a combination of the three. Or maybe the patient took the wrong insulin and didn't eat enough, or let's say took too much of the hypoglycemic agents, or let's say stayed on their current therapy but then increased their physical activity or engage in an exercise regimen without making any changes in their insulin therapy. Remember that exercise has the same effect as insulin. Yeah. So it promotes hypoglycemia, yes, because it increases the uptake of insulin, glucose by the muscles. Okay. Or maybe not mentioned here is alcohol, because alcohol will cause hypoglycemia if taken without food. So that could be another cause. Older adults are especially at risk. Here are the reasons. Okay. Another danger here is if the patient is skipping meals or if that elderly person is on beta blockers. Okay. Because most of the manifestations is hypoglycemia life-threatening. Yes. So a life-threatening stimulus like this one, will it trigger sympathetic nervous system stimulation? Yes. If the patient is taking beta blockers, will it still manifest the sympathetic manifestations? If the patient is taking beta blockers? Yes or no? It will suppress the sympathetic manifestations. Okay, so is it dangerous for elderly people, especially taking beta blockers, to have hypoglycemia? Because they won't have the usual manifestations of hypoglycemia, which are mainly sympathetic in nature. Okay. All right, so manifestations. Here we have mild, moderate, and severe. I won't read the whole thing for you. They will increase in severity. So in mild, for instance, again, automatic stimulation of the sympathetic nervous system. So patient will have these manifestations for mild. And then for moderate, it increases. In addition, the patient will have these manifestations now. And three, severe hypoglycemia, mostly CNS changes, including loss of consciousness. However, even though the textbook mentions mild, moderate, severe hypoglycemia specifically, manifestation specifically, each patient tolerates hypoglycemia differently. Let me give you an example. I've seen a patient with a blood sugar of 60. Is that mild or moderate or severe? 60. That's mild. The patient was unconscious. On the other hand, I had a really old geezer, probably 90 years old. We were talking, he was talking to me, he was making sense. Lab called and told me that the blood that was just drawn shows a blood glucose of 25. Is that mild, moderate, or severe? That's severe. So you can see the difference there. So that's why my conclusion is each patient, each person tolerates or manifests hypoglycemia differently. All right. So when you treat it, are you going to treat based on the level or the patient's symptoms? Okay. Of course, the rule in the hospital is you treat based on the level, meaning if your patient has mild, of course, what's the treatment? Is it oral or IV? Oral. However, if the patient was, the example I gave you, was 60 years old, younger person, but had a glucose of 60, but was unconscious, what am I gonna do with the sugar and the candy? Am I gonna shove it in her nose or her ears? Okay, so see my point? So you treat based on the symptoms, okay? All right. So you don't always necessarily have to follow based on the level, okay? Because sometimes the patient's manifestations prevent you from implementing the standard interventions. Is that clear? And then the same example, that guy, that 90-year-old who had a sugar of 25, do I necessarily have to give him an IV dextrose or an IM glucagon? Do I have to? He's awake. So can I feed him instead? Which one would you enjoy more? An IV dextrose, an IM glucagon, or a burger?
Oh,
No, I'm not saying I gave him a burger, okay? I gave him a snack and a lot of snack, okay? So he ate, so he enjoyed it, okay? So he had crackers, he had juices, okay? So it was better than an injection, yeah? Okay. And until, of course, our intervention would, of course, be, what's our goal?
Bring it back to normal level.
Be specific. What number?
Put it back in the 70s.
Okay, 70 or better. All right. So once you hit 70, then the acute hypoglycemia is over. All right. But are these interventions here, the interventions here, such as treating carbs, 15 grams, that's the usual, right? So about a few crackers, a glass of milk or a glass of orange juice, that's 15 grams, correct? Are these, or even the IM here, sub-Q or IM glucagon or the IV dextrose, are these permanent fixes? Will it treat the hypoglycemia forever? No. How come you guys don't have hypoglycemia? What did you do? You ate, right? So therefore, after I implement the emergency measures and I reach 70, is that the end of my interventions? What should I do? I'll give the patient a snack or a meal. All right, depending on what time it is, right? So if it's still 8 p.m., breakfast isn't until 8 a.m. So what am I gonna do? Do I stop at the crackers and milk? Or do I give them a snack? I give them a snack, okay? So let's say it happened at 11 a.m. Hypoglycemia happened at 11 a.m. So what do I do after I gave juices or milk and crackers? I reach 70. So what do I do? It's 11 o'clock. The meal now should be coming, right? You see what I'm saying? Okay, so it depends on what time it is. But the important thing is you understand that this is not a permanent fix, okay? So just like everybody else, diabetics need to eat. All right, are we clear? Don't tell me, that you're in school and then you just do, okay, here's my lunch now. You shoot up IV dextrose or you give yourself an IM glucagon, right? These are temporary emergency measures only. These are not permanent fixes. Okay, this just for an emergency interventions only. All right, a warning for glucagon though. I should stay here. Glucagon is an emergency hormone. Just like any other emergency hormone, they will do what? Stimulate sympathetic nervous system, correct? And what will be the effect of sympathetic nervous system when my heart rate increases, when there's vasoconstriction? What is the vasoconstriction for again? To shunt blood, correct? Where will the blood go? To the brain, heart, and lungs only, correct? So what happens to blood flow to the rest of my body? Decrease, correct? So what happens to peristalsis? What happens to peristalsis? Decrease. Okay, so there's a warning here. So when you give glucagon, it induces nausea, vomiting. So what should you do after giving? If you choose to give glucagon, what should you do? You know it's going to cause nausea and even vomiting. What does the rest of the statement do? Say. Okay, so here. So if this occurs, turn the patient to the side because some of them will vomit. All right. Okay. So because of this, I really don't like the glucagon option. Okay, so I prefer the dextrose. Unless my patient doesn't have an IV access, I'll have to give glucagon. But what should I do? Put their head up and then head turn to the side. Okay, don't forget this, okay? This will happen, all right? It's even more dangerous if the patient is unconscious. Remember, when do we give the IM glucagon or sub-Q glucagon or IV dextrose? For mild, moderate, or severe? In severe, usually. And what is the patient's manifestation when it's severe? They usually are unconscious or at least lethargic. And of course, teaching so here's the beta blockers warning earlier. Okay, so this will mask the typical manifestations of hypoglycemia. So watch out if your patient has these. Okay, reminds me, I was humbled because a patient's family member called because the patient told them, they talking to the patient, and the patient told them, oh, I was given 7 units of Lispro, Humalog, and they felt, oh, that's too high. It's dangerous. She's never gotten 7. So they called the station and then pretty much chewed out, nurses. I'm the night nurse. This was given, at dinner time, which was at 5 o'clock. So I don't know what happened 2.5 hours ago. So I know, yeah, it was charted that nurse gave 7 because that was the order. Okay, that it met the range. Okay, doctor ordered if it's over 275, give 7 units. So that's what the nurse did. But they said, blah, 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 right? So I said, okay, yeah, I'll check your patient. But it wasn't my priority because the patient was conscious when I saw her. Okay, I took her vital signs. She's fine, she's talking to me. Her skin was warm. But when I did check it 30 minutes later, it was low. And I just realized because I didn't have to give her beta blockers. She was given beta blockers during the day. But because she was on beta blockers, did she manifest the usual hypoglycemic manifestations? No. So I was humble. I said, oh. So it reminded me always listen to the patient or the patient's family. They may not always be right, but they have a point. All right. That's it. Any questions on hypoglycemia? All right, let's go straight to hyperglycemia. There are 2 acute complications, hyperglycemic complications. Let's look at DKA first. So what is DKA? So thank you. So this is an absence or inadequate amount of insulin. Okay. So how did this happen? Before we go to pathophysiology, so how do we know the patient is in DKA? The patient has severe hyperglycemia, profound dehydration, and acidosis. Okay, so these are the 3 main features of, we have other manifestations, but lab-wise, this is how the patient will look. Okay, they are severely dehydrated. We'll discuss why in a moment. Let me go to the pathophysiology right here. Okay. So how did this happen? So this happens to type 1 and some type 2 diabetics. Used to be during my time 30 years ago, we hardly saw any type 2 diabetics go into DKA. It was usually type 1. we have more and more cases of type 2 diabetics with who go into DKA now in the modern era. Probably because of increased insulin resistance. As you know, type 2 diabetics can also take insulin, yeah? It wasn't just the type 1s. Anyway, so this is what happened. The trigger usually is right here. The patient got sick. Because how did the patient go into lack of insulin? Usually the trigger, like I said, is they got sick. Illness doesn't have to be physical though. It can also be mental or emotional. So let's say Sering and me are going out, okay? So I'm madly in love with Sering, and she just one day said, I don't want to see you anymore. So how does that affect me? I'm diabetic. Oh, just like that? Sering, how could you? And then what happens to my cortisol levels now? Increase. Because let's say I was never given any proper education on acute complications. Nobody told me about hypoglycemia, DKA, or HHS. In my humble understanding, because I'm so emotionally, well, I was sad, right? I was saddened by her dumping me. So will I have any appetite?
No.
No, I'll stop eating. Because I know that, oh, if I eat, I'll have food, yeah? I don't know about cortisol and all that. All I know is I don't like eating. I'm not eating. So what will I assume my sugar levels are?
Oh.
Of course, I'll assume it must be low. Will I bother checking it? I'm depressed. No, I'll stop checking it. I know it's low. I haven't eaten. I drank a few things, but drank some water, but I haven't eaten, so I know it's going to be low. But is it really low? No. So if you look at the pathophysiology, because I stopped checking my insulin, assuming it was low because of I stopped eating. No insulin, yeah. I haven't checked my sugars. Of course, I'm not taking my insulin. Okay, because I assume why would I take insulin? I know my sugar's low. Am I crazy? I'm gonna drop my sugar some more. I'm not taking any insulin. So I'll just, for a few days, I'll do this. So I'm just gonna be thinking about, watching pictures of sharing, and then, just reminiscing our time together. Probably send her a few messages, call her. No, I'm not gonna call her. I'll just send her a message, okay? With tear emoji, and then no. Then I'll talk to somebody maybe. Okay, Gabby, my friend. Gabby, you know what happened? I'll talk to her. Right. So meanwhile, my body, this is what's happening in my body. Because I'm not taking any insulin. So what would happen to my sugar level? It will rise, right? Plus cortisol didn't help. Cortisol maybe break down more glycogen, yeah, from my liver, yeah, adding to my hyperglycemia. I'll have these manifestations, and meanwhile, because I stopped taking insulin, so after glycogen, what will my body break down next? Fat, yeah. So it will break down fat. Um, and what will it break down next? Protein, yeah, muscle. Okay, right. So that's gonna happen. Background. My sugar levels are now like 150, then now 200. When it reaches 250, that means my fat is already being broken down. So now I have ketones, right? So I have ketones at that point at 250. So when I reach 300, my proteins are already broken down. So in the meantime, my sugar is going higher and higher. I have manifestations. I have the 3 Ps, yeah, polyuria, polydipsia, polyphagic, but I'm not going to eat, okay? Because again, I'm very, very depressed, okay, about what happened. Here's the fat breakdown side, fatty acids, ketones. Now I'm in acidosis, yeah, and then cause these symptoms. I'll have nausea, vomiting, abdominal pain, and then what do we call these respirations again? Cool small transpiration. Okay. Then meanwhile, the dehydration gets worse and worse because of osmotic diuresis. So I'll be peeing like crazy, and that will start with my dehydration. Okay, so that's what's happening. So what was the root cause of everything? Well, lack of insulin, right? Triggered by illness, yeah? So was I physically sick? Did I have the flu?
No.
Not necessarily, okay? But it's gonna happen also. If you have the flu, respiratory, symptoms, or let's say GI symptoms, you got diarrhea, nausea, vomiting, whatever you're experiencing. So even heart failure, okay? The patient's in heart failure, so they got sick, yeah? So it could be any physical illness or emotional, some emotional, you can still say illness, yeah? So I have that condition, so I stopped taking my insulin. This is the problem. Trigger, of course, is illness, yeah? Either physical or psychological stress. I stopped taking insulin, or could it also happen that I didn't know I was diabetic? That's possible, okay? So I had no idea I was diabetic. So therefore, I did not take insulin. So some cases of DKA is the first time the patient found out that they have diabetes. They had no idea. They found out the hard way, almost killed them, right? So this is what's happening. So now, of course, prevention, of course, is we should educate every patient who has diabetes, whether newly diagnosed or already diagnosed. We should supplement it, okay? Reinforce. Do you know what to do when you're sick? And of course, emphasize illness doesn't have to be physical, okay? So if you're, let's say, under stress, exam, can this happen during exam weeks? Yes, patient can go into DKA during examinations. Okay? So we should know, they should know what to do when they're ill. Okay, so sick day rules, we have a chart. Let's go to 46-9. So this is what you'll do. Continue checking your sugar. This is the most important. The second bullet is the most important. Continue checking and then tell them about what is the effect of a physical or psychological or emotional stressor on blood sugar levels. What is the effect? You're teaching them. So what do you tell them? No. What is the effect of a physical, emotional, or psychological stressor on blood glucose levels? Will it go up or down? It will increase your blood sugar levels. If I ask, what the hell are you talking about? I haven't eaten. Okay, so I'll tell you, you're telling me, after Saring broke up with me, you're telling me I haven't eaten and my sugar is going up? That's crazy talk, okay? That's a conspiracy theory. How did you come up with that? So how do you answer? Where did the sugar come from? I haven't eaten anything. Okay, so here, go back to the pathophysiology here. Where did that glucose come from? From my liver, from my fat, from my muscles. Okay, so therefore, what do you tell the patient? We are made of glucose. Okay, so yeah, we have glucose in our liver, emergency, right? When you're sleeping, that's what we live on, the glycogen in your liver. And in starvation modes, we have fats here. I have a lot of food right here. This will last me throughout 3 winters, okay? I have enough here, okay? And plus I have some muscle, so I will survive. So all of us here, who will likely survive starvation? I'll be the top, okay? So I have the most stores, okay? So that's prevention. You tell them what to do, continue, check your sugar, and if it's high, take your insulin or your metformin, whatever you're taking, if it's high. And then check unlike before, wherein we have to go to a lab to check urine for ketones, we don't have to do that anymore. We can do it at home. We have urine test kits. Okay, we have ketones, they're like $7-9, depending on the brand. So we can do this at home now. Just get a urine sample, dipstick. It'll tell you whether or not there's ketones, okay? And it's covered by insurance. Keep eating. If you can't eat solid food, then drink food. Okay, Glucerna, right? That's the supplement for diabetics, yeah? Or anything, yeah, juices, whatever that has, nutrition. Okay, keep eating, drinking if you can. If you can't take anything down anymore, then go call 911 or go to the ER. All right? That's what you teach them. Very important is stay hydrated. Why do they need to stay hydrated? Here, because of the diuresis right here. Okay, so there's polyuria, osmotic diuresis. We discussed this 2 weeks ago. And again, if you can't handle it at home, it's time to, okay, go to the ER or call 911. Manifestations, so manifestations of hyperglycemia. Okay. And again, because there's Kussmaul's respiration now, deep rapid respirations with a fruity or acetone odor. So here's the explanation. The Kussmaul's respiration is a compensatory response, yeah, to the acidosis. Labs now. So when your patient comes in, what will they look like? Fluid overload or fluid deficit? Fluid deficit. Okay. So manifestations of fluid deficit, what are they again? Heart rate will be, blood pressure will be, low. Respiratory rate will be high. Okay, so neck veins will be, what will be my weight? Lose weight. What will be my urine output? Dehydration already. Oliguria or diuresis? Oliguria. Will I go into AKI? Yes. What type? Pre, intra, or post-renal? Pre-renal AKI. Okay, remember dehydration. Okay, severe dehydration. So I have DKA. Do I also have AKI? Yes or no? I'm profoundly dehydrated. Do I have AKI? Yes, I'm not discussing AKI anymore. We finished that last week. Okay, so remember, this chapter will only discuss DKA. All right. So dehydrated, look at what will be my hemoglobin hematocrit? Hemoglobin will be, hematocrit will be, very good. Okay, BU and creatinine will be, very good, children. Okay, now because I have ketone bodies, what will be my pH? Give me a number. Low. Okay. All right. So 6.8 to 7.3. Okay. And low PaCO2 because there is Kussmaul respiration. Yeah. Okay. And low bicarbonate, also indicating acidosis. So on the exam, you'll see this. If I give you a drag and drop, okay, or a matrix, can you answer that? So here's your answer right here in this paragraph, okay, for labs and findings. Okay. So BN creatinine will be high. Okay. All right, let's go to management now. Now what do we do? Now this management is in order. All right. In this sequence. First is fluids first. Because ABC, right? Is there really a oxygenation problem here? No. There's increased respiratory rate, but this is caused by, what's causing my respiratory rate to be high? Is it because I have a gas exchange problem? This is only a manifestation of the hyperglycemia, right? This is the acidosis talking, right? That's why I'm hyperventilating, yeah? So I need what first? Fluids first. So you saw today, you practiced today how to hang an IV bag, okay? What will be the rate here? Do I get fluids a little bit or a lot? Look at this. The patient will need 6 to 10 liters of fluid. That's how dehydrated I am. That's how bad my acute kidney injury is. Okay, so I need lots of fluids. So let's say the order is, look at the second paragraph. Initially, 0.9% is given at a rapid rate, 0.5 to 1 liter for the first 2 to 4 hours. So let's say first hour or two, I get 1 liter per hour. So how much will you program on the pump? Rate and volume. Why did we get 100? I said 0.5 to 1 liter per hour. Let's say the order is 1 liter per hour. So what will be your rate and volume on the pump? There's no liter on the pump, right? What was the unit? ml. So how much will you put on the rate? Okay, you'll discover next week though, when you go back to the lab, the pump won't let you put in 1,000, at least this pump. So the maximum you can put is 999. It will only give you 3 digits on the rate. On the volume, you can put 4 digits. You can put 2,000 there, you can put 1,000, okay, whatever. But most of our bags, do we have 2-liter bags? No, we only have 1 liter. So you'll put 1 liter bags at a time. Okay, so this is the first hour, okay? So we're still on the first hour. Are we clear? So you just hung the bag, programmed the pump, and started infusing. Okay, so we're not on the part yet. So this will come later. Okay, so first hour, 1,000, yeah? So we still got what, 59 minutes to go. All right, so it's running. What's next? So we'll skip here for now because we won't hang the half normal saline yet because this is still the first hour. So let's go to the next one, restoring electrolytes. So based on the patient's lab work, you will replace depending on the electrolyte imbalance. Which one is low? Is it the sodium or is it the potassium? And then replace it. Okay. This is the other thing you need to do. Reversing acidosis. What caused the acidosis? Go back to the pathophysiological, the diagram. What caused the acidosis? Why did the ketone bodies form? What caused the ketone bodies to form? What? Broke down what? It broke down fat. Why did it break down fat? What was the first box on top? There was no insulin. So therefore, how do we reverse acidosis? Knowing now this is now the chain reaction. We give insulin. Clear? All right, so let's give insulin. What type of insulin? Regular insulin only. Okay. So because this is given IV. So the only insulin you can give IV is regular insulin. Continuous rate, 5 units per hour. Depends really on the glucose level. Okay, so let's discuss the insulin infusion. This will have to be prepared by the pharmacy. Okay, you don't mix the bag. Okay, so soon as the order is put in, pharmacists will send you the bag right away. Or if not, you call them, hey, where's my insulin bag? I need it right now. Okay, patient's critical. So they'll already, oh, give me 5 minutes. Okay, they'll prepare it. Okay, send it up to you. So now you have the bag, and there's a warning here. Right here. When hanging an insulin drip, can someone read this, please? Elisa?
Insulin molecules adhere to the inner surface of plastic IV inclusion sets. Therefore, the initial fluid may contain increased concentration of insulin.
Do you understand what this is saying? So I have a 250 ml bag. So let's say this is the bag. Let's say this is a bag of insulin. Does anyone have a bag? Ah, right, this bag. And this is insulin. Okay. And I spike it. Yeah, with the tubing. What did I do with the tubing again? Clamp, and then spike this. And then I'm going to
Fill the
close
chamber.
the drip chamber. This is a primary line. And then I'll prime it, right? When I prime it, what does this say?
Let it wait for it to come.
Okay, because the first 50 ml, the insulin will stick. Yes, the fluid will come out, but is insulin coming out with it?
No.
No. What happened to the insulin? It's stuck to the inner surface of my tubing. It will do that for the first 50 ml. So I need to discard 50 ml. How do I know I discarded 50 ml? Are you just gonna estimate? That sounds about 50. How do I know?
So.
Does the bag have lines indicating how much?
Yeah.
No.
Oh, you use a syringe,
Holds a cylinder.
the big syringe.
I'm
Full of.
priming it in the tubing.
I mean, you can run
Uh,
the pump.
you-
I'm running it through the tubing. Okay, so one option she suggested is run it through the pump and program 50 ml. That's an option. You can do that. I'll take that. So you can program the pump to run 50 ml fast. Okay, put 999, waste 50 ml worth. Or can I put it into a measuring cup? That's an option. Okay, we have medicine cups that are 30 ml. I'll put 30 and then 20 on the next one. That's 50 ml. Yeah. So many ways to do it. The textbook won't tell you how to do it. It just tells you to waste how much? Discard 50 ml. Because if you don't do this step, you don't discard, what would happen to the patient during the first 50 ml? Are they getting any insulin? No, because where did the insulin go? It's stuck in the plastic tubing. It did not all go to the patient. Maybe the patient got some insulin, but most of it stayed in the tubing. Are we clear? Right. So the rate here, so this is now in preparation. Your first patient will be a DKA patient. So let's say the rate is 0.1 units per kilogram per hour. Okay, not 5 units per hour, 0.1 units per kilogram per hour. Patient weighs 60 kilograms. And your insulin bag is labeled 250 units of regular insulin and 250 ml of NS. What's the concentration? 250 ml, 250 units. Oh, you calculated on with your pens. So 250 units in. This is the bag labeled 250 units of regular insulin and 250 ml of normal saline. So what's the concentration of this bag? How many units per ml? 1. You understand? Okay, so if my order is 0.1 units per kilogram per hour, my patient weighs 60 kilograms. How many mLs per hour will you program? Oh.
6.
So the order is what? How many units is this? 0.1 units per kilogram. So how much?
6
6 units, yeah? I need to give 6 units.
per hour.
And this is my concentration, 1 unit per ml. So how many ml per hour? I need to give 6 units. This is my concentration of the bag. So how many units, how many ml per hour? 6 ml. All right, okay, so that's the infusion. However, there's also a bolus ordered. Doctor also ordered, okay, give this patient 0.1 units per kilogram IV bolus. So this is a continuous infusion, correct? This one is an IV push bolus. How will I give this? And how much, first question, how much will I give? How many units is this? 0.1 units per kilogram. So how many units? 6 units. Okay. Now you draw, you've seen an insulin vial, yeah? Regular insulin vial. You've seen an insulin syringe. I draw up 6 units. Now what? The route is IV. What will I do with that 6 units of insulin in the insulin syringe? Huh? Which bag?
Normal thing.
This bag? If I put the 6 units in here, will the patient get that 6 units? No, you put it in the bag.
If you just insert it.
So it's not 250 units anymore. Now there's 256 there because you added 6 more units. So what will I do? I need to give 6 units IV bolus. It's in an insulin syringe that has a needle.
I wish that.
How do I push it? All the ports are needleless. You saw the IV tubings.
Yeah.
Yeah, that's what I'm saying, insert it.
The connection
into
is
the
not-
wide piece of paper.
The white piece is needleless. It only takes a needleless syringe, a lower lock syringe. It can't take a needle.
Okay.
The needle will bend
Is
or
there
break.
Is there some other
Go ahead.
device that will connect?
So what device did you use to push fluids?
Flush.
A flush. So what do you do with the insulin?
You flush it.
I take the needle off. How? Break it like this?
No.
Yeah.
Like that? How do I do that? The needle on an insulin syringe is attached to it. Can't take it off. It's connected. So you're gonna break it? How do I do it? Yes? Put it, transfer it to a lower lock syringe. So you get a flush. 6 units is what? This is 6, what, how much 6 units is? Yeah, that's 6 units, okay? So you put that into a flush, mix it with saline, push the air out. Now, do I have 6 units of insulin in that small little flush?
Yeah.
Can I push it now?
Yeah.
Okay, that's how you do it, okay? So now I don't want to say anything silly when you do your simulation in 2 weeks. Okay,
2 weeks.
yeah, a week from now, so we'll practice next week. Following week, what is that? Week 5, we'll do our simulation, okay? So you gave the 6 units push, and then you start this at the same time. Okay, so how many pumps do we need? How many? How many pumps? Didn't we discuss our pumps can only run 1 fluid at a time? So do we wait for the 1 liter to finish before we can give insulin? 2 pumps. So remember, this is still the first hour. We just began 10 minutes ago. So the saline is running at 999 ml per hour. You gave the push, and then now you're running the dextrose or the insulin. The insulin on another pump. Okay, so they're running at the same time now. Okay. So here's and what do we do? Meanwhile, this is running, so what do we monitor every 15 minutes?
Vital signs and.
Glucose, okay, check glucose, because remember, this is insulin, okay? Remember what we did, what was one of the interventions for hyperkalemia? That involved insulin and dextrose?
Yeah, 9
Yeah, okay. So what was one of the options to treat hyperkalemia?
Actually,
For regarding the IV dextrose.
Saline and dextrose.
Together, right?
Yeah.
Yeah, and then you gave it, and then what happened to the potassium level?
It
It
shifts.
shifted, right? So what happened to the serum potassium level? Went up or down? You said change.
Went down.
Went,
Down.
what?
Down.
It was up in the first place.
Yeah.
You want it
Went
up
from
some more?
the-
So what happened to the serum potassium level? Okay, so it went down. It shifted, right? Okay. What will be the effect of this insulin? This is also regular insulin IV. So yes, it will drop that sugar. What will it also drop? Potassium will also drop. Okay, so what do you monitor? Potassium levels. And if we needed, if the potassium drops, what will we do? You replace. All right. Sometimes the doctors even give it ahead, meaning they won't wait until the potassium drops. Because what did we learn 2 weeks ago? Is it easy to correct low potassium? No, it took forever, right? So therefore, some doctors will say, put potassium. So this fluid right here, the second fluid, this one, the half normal saline, the 0.45%, doctors may add potassium here. Doctors may order this as 0.45% NS with 10 milliequivalents, with 20 milliequivalents of potassium per liter. Right? Some of them do that because they know potassium will drop as long as this fluid is running. Okay, because yes, this will lower sugar, but it will also lower potassium. It will, right? We saw that in hyperkalemia management. It lowered potassium. Okay. So they might do that. So let's say when the first liter of saline is finished, doctor will say, okay, doctor, the 1 liter is finished. Now what? They say, okay, how's the blood pressure? The blood pressure stable, they say, okay, switch to here. But if the blood pressure remains low, they'll order another liter. If blood pressure is still less than 90 systolic, they'll say, okay, run one more liter. Okay, same rate, 999, another hour. Then we'll see how it is when that's finished. So after, let's say, the second liter, blood pressure is now stable. Okay, blood pressure is 95 over 60, something like that. Okay, so it's good. Remember, what's the MAP for 95 over 60? That's over 70, yeah? So we only need 65. Okay. So now we may have an order for this one with potassium. Okay. At a slower rate though, because we don't switch to this until the blood pressure is normal. Once the blood pressure normal, do we need to give 1 liter per hour? Don't need that anymore. So now this one is just to maintain, okay? Maintain blood pressure. Plus, will this help with the dehydrated cells? Because this is hypotonic, so where will this go? Into the cell now. This will go into the dehydrated cells. Because remember, this 1 liter of NS did not go anywhere. It stayed in the bloodstream only. So the cells remain dehydrated. They were not fixed yet. They had to wait. Because which one's more important, blood pressure or the cells? Blood pressure first. So that's it. And then at the same time, this one. Because why is this called? Why did this fall under reversing acidosis?
Because you're all.
Yeah, it fell here. So this one is rehydration. We understand that. This one, and this one fell under reversing acidosis. How did this reverse acidosis again? Remember the cascade again. Okay, remember the pathophysiology. It was the lack of insulin that led to fat breakdown, that led to ketone bodies, that led to acidosis. So therefore, what is this intervention for? Reversing acidosis. This is for reversing acidosis because it wasn't simply the hyperglycemia, it was the lack of insulin that caused the whole problem in the first place. So you give insulin, you stop the acidosis. However, if the patient's pH is too low, we may need to give bicarbonate. Yeah, I can't find it, but no, this one just says if the, insulin will be continued until the serum bicarbonate is normal. Okay. However, the right here. So, yeah, thank you. So in general, thank you for reading, Chelsea. In general,
General bicarbonate infusion to correct severe acidosis is avoided during treatment of DKA because it participates for the sudden and potentially fatal decrease in serum potassium.
remember that also? What was the effect of sodium bicarbonate? Of bicarbonate in hyperkalemia? Decreases it, right? It also shifted it. So we only give bicarbonate if the patient's pH is like less than 7. pH is less than 7, meaning 6.9, 6.8. That's too much. Okay, that's too acidic. Patient may have brain damage as a result. So we have to give bicarbonate. But if the pH stays around 7, 7.1, leave it alone. Okay, that will eventually correct itself once this thing works. Okay, so once the sugar levels stabilize because of this, the acidosis will also stop. Okay, it will reverse itself. So when do we give bicarbonate? Only in severe acidosis. All right, we'll stop right here. We have no more time. Quiz will be up to this part.